Welcome to Tapping Wisdom. I'm Sue Padernacht, and I'm delighted to welcome Dr. Michael Privitera, who is the Emeritus Professor of Psychiatry at the University of Rochester Medical Center and past director and medical faculty of the Clinician Wellness Program. His focus throughout his life has been on clinician and patient safety, well-being, and taking a look at the factors that contribute to burnout from a cognitive standpoint. So Dr. Privitera and I have met through the clinician burnout community, and I was delighted to be part of one of his early sessions before some of his papers came out then. So it's been wonderful to see how this work has evolved. So Michael, Dr. Privitera, welcome to Tapping Wisdom. And I'd like to open it up to see what more you can share about yourself and how you came to do this work.
Thank you, Sue. It's good to see you again.
Yeah.
Well, I'm a clinically retired psychiatrist, the kind that were consultation liaison psychiatry that would go to the hospital, see people in the hospital. And as a result, I also got to meet and be with a lot of colleagues throughout the hospital of all different services. So it gave me a good view of, seeing what goes on in the hospital, knowing the colleagues, but also I clinically took care of many colleagues dealing with stress and depression and the anxiety that came from this. So I got quite a unique view. So it's helped me to be spurred on to do this kind of work.
Okay, thank you. Thank you. So a lot of what we've talked about has to do with the human factors and the cognitive elements that contribute to burnout. Can you
Right.
talk about that? What is that? Why is that important? And what is some of the research showing regarding the implications of that?
Yeah, absolutely.
Hmm?
Well, human factors is a field of study that includes many sciences in terms of cognitive science, organizational psychology, medicine, safety science, etc. So it's a conglomeration, which is kind of the best of those issues then, especially the ones that relate to each other. Human factors really came to my interest, especially it began with my previous work in workplace violence and looking at organizational contributions to workplace violence. And I got mentored by Vaughn Bowie, who was from University of Western Sydney, who was a world expert in that. So getting to look at what does the organization do that affects people, which then affects patients. So when healthcare reform came out in the early 2010, 2011, and the influx of electronic medical record, plus all the issues that came with that in terms of very well-meaning metrics for patient safety, metrics of different kinds of performance, always and mostly end metrics, the result that occurred, not necessarily anything that gave you a picture of what was going on upstream that led to that. Just seeing how many expectations were now coming down on clinicians, I got the sense that, wow, they can't do this. I mean, it's more than humanly possible, but they're not going to listen to me unless there's some science behind it, because you can't get very far with emotion alone. You need science. So I looked into what kind of science might explain this, and as a result, looked at, well, what happens with aviation? What happens with space exploration? How is this applied already? And that science was human factors, and ergonomics is another name for it. Seemed to make a lot of sense because the object of human factors ergonomics is system performance and human well-being, which seemed like the perfect marriage. That's what we're looking for, is systems to work well and the well-being of those that are doing the work. And one of the outcomes that comes from that is patient safety. If the system was working well, patient safety comes from that. So human factors and ergonomics I've been looking into the last 15 years or so, and trying to see how this can be applied in leadership education as leaders make decisions about resources, they make decisions about workflows, and unfortunately, the way our system is set up, it's usually one-way communication from the C-suite, where the chiefs are, and hospital leadership, down to the clinicians, without feedback systems that can say, how's this going, and can I do it? And therefore, there's an accumulation of more and more expectations. So it's kind of a blind spot that's occurred by leadership structure in hospital systems. As you know, there's hierarchy, gatekeeping, so you can't necessarily get information to the top where it's needed, and
Yes,
which
and
would be
I
benefiting.
also wonder how how the people at the top can also do their jobs too, right? I mean, if it's almost,
Right.
I mean, at every level of the system, the load, and I would love to
Yeah.
ask you to talk about cognitive load in a moment, but the load is everywhere, even though it's different, even though at the leadership level it's not at the bedside, but
Right.
it's expanded, manyfold,
Absolutely.
in the last, 10, 15, 20 years at that level
Absolutely.
as well. So how much capacity is there, for
Right.
there to be, taking a look at these things, unless you have the science to and the consequences to prove that. So I'd love
Exactly.
to pass that back to you,
Yeah.
talk about that and cognitive load.
Absolutely. In fact, the American Hospital Association did a great report, I believe, in 2017 or so, about the impact of all the regulations and metrics and what happens at the C-suite level. So empathy for the C-suite of having to deal with regulations as they come through, that it's more cognitive load figuring out how do we apply this. We need more staff to do it. So it's more hires, not necessarily improving clinical outcome, but you must do it if in order to get paid by the powers that be. So definitely at the C-suite level, it's overwhelming. So the importance of human factors and cognitive load is that, well, there's a science to try to make this work better within human limitations that there are at the administrative level as well as at the clinical level. So we're all overwhelmed, and we all feel that in our society as well, being overwhelmed. So this is a timely science that I'm very hopeful that spreading more information about human factors might be helpful. So what is cognitive load? Cognitive load basically is a kind of a measure of the work that's involved cognitively through your thinking process to manage what it is you're dealing with. Either it's learning new material, it's being able to handle and figure out what's being said, how to put that into your long-term memory, how you're learning things, how to draw from your long-term memory, get it back into your present information. So through educational science, John Sweller in Australia and his colleagues talked about cognitive load theory, and he divided cognitive load into three parts: intrinsic cognitive load, germane, and extraneous. So intrinsic is basically somewhat not able to be lessened, except the more experience you have, the less intrinsic. So intrinsic is basically what it is you have to learn or deal with. The more experience you have and education, that is lessened. So somebody that's a novice might have higher intrinsic load in trying to deal with the situation, like a novice surgeon versus an experienced surgeon.
So, in other words, intrinsic load is basically objectively the level of difficulty of something, regardless of what someone's experience and expertise is in it.
Well, except the
It's
experience,
objective, right? Like
yeah,
how much calculus is versus algebra versus arithmetic.
yeah, that part's true, but the intrinsic will go down the more experience and education you have of the same thing because
I
you've done
see.
it before.
I see. Okay. Okay. So it is subjective experience as
Yes.
well. Okay. Gotcha.
And then germane is the issue of how much that mental energy it takes uh, to conceptualize and make a mental model of what it is you're dealing with, and then that mental model could go into your long-term memory. Or it's the same in reverse, it's pulling from long-term, bring it into your working memory. And then extraneous is that can be removed by better design. So looking at, are there too many expectations? What are the policies we're writing? Uh, and the trouble with extraneous cognitive load, that is something that can expand quite a bit and run your thinking capacity over the limit where you start making mistakes. So that's something we're um, getting, getting smarter about our policies, getting smarter about our expectations. We can reduce extraneous cognitive load, get it within the working functionality of our brain, and making less mistakes and less stress. So that's our objective.
Okay. Can you give us an example rather of germane cognitive
Yeah,
load? Yeah.
Jermaine, like the better you are at, this is why it was so important in education. How you teach might make a difference. How you make presentations might make a difference in how that person learns. So that's germane load. So you want that less too. So you wanted smarter ways of teaching, smarter ways of presenting, because if that's bigger, then that takes up more of your cognitive space. And so
Okay.
you
So
want
it's
your
almost like
total,
efficiency, like how things get
yeah,
done. Okay.
yeah.
Got it. Got
And
it.
that's especially true with how you're learning or conceptualize what somebody's telling you.
Sure. And with extraneous load, I could hear the debate between, the people in administration who think that some policies and steps are necessary from a legal, operational, etc.,
Right.
security standpoint, even like dual authentication, right? In
Yeah,
electronic medical records or in anybody's system, right? How
absolutely.
annoying, right? And time consuming that can end up being when you're trying to go quickly. But the IT people will say for cybersecurity reasons you have to do that because there's too many
Absolutely.
bad actors out there. So one person's extraneous is another person's essential.
Yeah.
Right. So,
Well, it's
so
true.
talk about that. Yeah.
That's where from an organizational system, try to get people in the same room. Uh, and so that people are hearing the same, because sometimes what gets made is decisions in isolation without being involved in collaborating with all the sources. Everybody needs to do their job, and most people are doing the best they can. So we got to, be empathetic to the fact that um, these things need to be done. Regulations are there, but how we roll them out might make a difference. For example, when you think about how many times a year to change the password? Or is you go from once a year? Should you do it every 6 months? How about every 3 months? How about every month? How about every week? If you go to extreme, you know that there's a point where the risk exceeds the benefit. So
Mhm.
that's the more you understand about, well, now people aren't going to remember their password, or they're going to make more mistakes because they're working so much in this. So you need to think in toto, what are you burdening that brain with? What you want them to be able to think as much as possible about the patient in front of them. So how can we make this run more smoothly? One example would be mandatories. What we did at our institution is we got mandatories, by the way, come from all different sources. They might be the Joint Commission, they might be the State Office of Mental Health, Office of Department of Health, et cetera. They all add up in terms of expectations. So what we were finding is they were coming from different offices. So we wrote them all down, got them on the number of pages it took and what their source was. When we reviewed just the list with our chief of patient safety and quality of care, immediately within the first week, we got rid of 20% of them, because by looking at the total, he was able to see that some of them are outdated, some of them are duplicative, they can still meet regulations. So when you think about that, what are you doing? You're decreasing the split attention, in terms of how far apart two pieces of information are. You put them closer together on one page, and that's allowing you to think through the pros and cons a little bit better.
It's
So it's
like the old expression, do the left hand and right hand know what they're doing?
yeah, Yeah,
Right.
exactly.
Yeah. So it's all coordinated. That makes really a lot of sense. And I could see this applying, of course, to really any profession or any situation. I mean, I could see it
Yeah,
applying to, to teachers or people who working in tech companies or finance company. I mean, really, this applies anywhere in any organization. I so appreciate you telling me this. So if you could now talk a bit about your research and how you've seen the connection between human factors and cognitive load on clinician burnout and the impact on patient outcomes.
right.
I'd love to hear about that.
Well, some of the research has been done by colleagues, but especially when you think about the clinical profession, when assessments are made of, in general, how much cognitive load there is in various specialties, the higher the average cognitive load in those physicians, the higher the burnout. Also, acutely with a task in front of you. So that's like chronically. Acutely, when you have a task in front of you, the higher the cognitive load, the higher the risk of medical error. So that's been shown in ICU settings and in radi radiologic oncology studies, that the higher the total cognitive load, the higher risk of medical error. So we know it's a real active component.
And I wonder about the role of the staffing shortage,
Right.
about distractions, about multitasking. There are so many factors that go into, extraneous workload and extraneous factors, right? So I'm wondering if you can talk about some of that.
Yeah.
Yeah.
Well, think of our brain as it's a cognitive resource and it's limited. So we want to use that as optimally as possible. So we want to get rid of things that may not need to be done by that person that's so highly trained. So once you get more of the science in the education and leadership, you can start to make real decisions about resources. And part of his cognitive resource. When that gets drained, we're more likely to make mistakes. So when we think about the resources, every decision we make uses a cognitive resource. So every click on an EMR is a decision. How things are spaced, where we put things in the screen for the EMR. Is it always is the like the medical record number always in the right place, or do you have to search and find where it is? That's using a cognitive resource.
Not to
Um,
mention all the emotional annoyance that comes up with that, right?
yeah,
Which
that's
adds
right.
more fatigue, right? All that emotional exhaustion that we know is part of burnout.
Yeah, and emotional exhaustion actually uses up our cognitive resource. So the emotions do too.
Yeah.
So say you're a
Point.
clinician, you're being threatened in patient violence or feeling that you're just so overwhelmed. That's that emotional uh, process uses up your cognitive resource. Same thing for being professional in the setting of various things. Person's bleeding, and you're trying to stop the bleeding, that takes cognitive load, just your professionalism and equanimitas, as it's called, in the setting of multiple things that are going on that are clinical, how you keep even and stable. That uses cognitive load.
Mm.
So it's a limited resource. The idea is that it's currently being ignored as to its limitations. But the more we get the science out there, the people can understand the fact that we're using it up. That's another reason for work outside of work needing to be addressed
Second
because we
shift.
need, yeah, we need to restore what's going on. Besides, people late at night will start writing gibberish uh, because their resources are expended and they're tired. So that should be concerning to lawyers that try to protect a hospital. They don't want people writing gibberish. So let's get human factors into the mix of how we decide things. So in
That's
other words, the hospital should care about the fact that work outside of work is going on in the sense that it drains the quality. It may drain resources because people may not want to continue to work at a place that doesn't look after their well-being that way. Because that's a good source of seeing what the metrics are for how well a hospital is taking care of their staff.
Sure. And while I don't want to go down this rabbit hole, I'm sure artificial intelligence AI is going to take some of the stupid work out, right? Some
Right.
or help like voice to text kinds of
Yep.
note taking that can actually help reduce some of that extraneous load. But at the end of the day, you still have staffing shortages, you still have distractions, you still have emergencies, you still have all of
Right.
these things that are pressing on people. So there is a lot of hope for AI to help
Yeah.
with some of that extraneous load. I'm wondering if you could talk a little bit about kind of the legal side of things. So you had referred to that. What are you seeing out there in terms of opportunities to work with our legal partners?
Yeah. Well, there's been papers in the last 10 to 15 years about legal remedies for burnout. In Case Western Reserve, there's an attorney that writes a lot about that, Sharona Hoffman. So I got interested in some of this work by the fact there's existing literature about, especially um, the emotional impact that it has, and now more information about how it's actually physiologically affecting our brain, which should be of concern not only to the individual, but the patients they serve, because the areas in the brain that are affected, like the prefrontal cortex, our memory, hippocampus, our emotional state, the amygdala, are all affected by this uncontrolled stress. So that's uncontrolled is where you can't get out of the stress, nor can you mitigate it. You don't have influence on mitigating it compared to those things that you can control better or they're temporary and you can get out of them.
And
The
we all
the
know
issue,
about the perception of control and
right?
agency. Even the perception of it can make so much of a difference, right?
That's
Being at peace with it versus not being at peace with it,
it,
regardless how much is also part of it. So I
exactly.
completely, yeah, following what you're saying.
Which also goes to some of the fact that under stress, the perception of access to the top, that is leadership, actually helps you to perform better under stress. Even if you don't really have the access to the top, but to feel like you have, that was a study differentiated that perception makes a big difference. So,
Absolutely.
which means all the more reason for thinking about why we need feedback systems from the front lines to those that lead so that they get real information about what it's like to be doing the job, which are sensors to the product of what that organization is putting out. So we already have it from patients coming, patient feedback, which gets looked at by leadership. We definitely now need to enhance that by clinician input. That's part of human factors science, which is called sociotechnical system design. So there's socio people and technology, the parts that make the thing work technologically. And we work on technology, but not enough on the people part.
So
So
I
we
would
need to
love to
jointly,
ask you a question right about that. Like, what recommendations would you make if they were, clinician, medical leaders listening to this?
right,
What recommendation would you make on that? So we already are doing a good job of collecting information about the patient experience. What would you recommend using sociotechnology and human factors? Uh,
right.
to whether it's hospital leaders or medical leaders in any situation.
Yeah. Well, one of the things that I've seen that is to me a little bit concerning about more than a little bit, in the sense that various consultants to the C-suite are talking a lot about tech solutions to various things that maybe are human solutions that need to be there, and getting more and more overwhelmed by new technology that may not fit so well how one fits to other technology. What we're now, how that interferes with your thinking process as a clinician, we're now referring to a word called techno-viscosity. The viscosity in your thought of getting to what it is you need to do, that all the technology is getting in the way instead of helping.
Oh, wow. Techno viscosity. That's a
Yeah.
new vocabulary word for me. Thank you.
So we need to adapt to the fact that there are new things that are happening to us humans if you're in the human club that that technology is doing. So what needs to be done more is more feedback systems to that are regular. We sometimes do um, once a year surveys that are might be burnout surveys. But what we need to do is regular and psychologically safe systems. Psychologically safe in the sense that person doesn't have to worry about their losing their job if they say something. That's really for better efficiency of the organization. And then leaders, take or leave what they think is best. But we need to listen more to the front line. And I think put in context what consultants are saying compared to what it is that your front line is saying. That needs to be a better balance than the way it is. Sometimes consultants prevail and the input from the staff does not. I've unfortunately seen that happen, which is very frustrating to the staff.
Especially technology consultants. Yeah. So, and and I found the same thing in my research that that people are burned out on surveys. They're kind of sick of
Yeah,
surveys, and sometimes they could just go click happy and
yeah,
just get it, just to get it
yeah.
done, right?
Get it over with.
So I mean,
Yeah,
and sometimes the date, you have that's noise, right? And there's ways of factoring that out. But there's nothing like, getting people's input, getting their voice into it and
right,
getting nuance and context because because you're hearing it from them as
right.
opposed to just kind of checking a number based on questions you asked. Because that's real, a survey is really, you know, it's one way in a sense in
Yeah,
terms of information sharing.
exactly.
Unless there's some open-ended questions. So what you're recommending is creating a feedback loop based on
Yes,
the human factors model that introduces the clinician voice and values the clinician voice as part of, not instead of course, but as part of the sociotechnical solutions that
exactly.
are the future, that are really the future. So we're valuing both and not either or.
Yes, yes, both and. That's right.
Yeah.
That's exactly right. And so the ideas of these feedback systems, allowing them to be built into how we how we do things, because we're all overwhelmed. We have to realize that technology is definitely out of pace with our cognitive abilities. So our human adaptation is way below the rate of technological accelerations of new things. So we have to be smarter about it. It's not going to work if we just add on without trying to also take away and realize what we can take away that might be extraneous cognitive load. If we think of lean process,
Mm.
what is waste?
Mhm.
We do that all the
Manufacturing.
time
Mm.
with lean process. And so extraneous cognitive load is basically the waste in comparison to lean. So we can use lean teams to look at this in new ways. So some of the structures already exist in our hospitals. We could just readapt how we're doing it to realize certain cognitive load is waste. So
Yeah. Yeah. And can you share with us anything that I have not asked that you would like our audience to learn about, know about, or something that that you just enjoy speaking on
yeah,
that I haven't asked about?
okay. Well, I think one of the models that we uh, have known in healthcare is how important hand washing is. And the person that taught us about hand washing was Semmelweis, Dr. Semmelweis, who realized in the postpartum period or for delivering babies that washing hands was the critical step needed to prevent postpartum fever. He was ridiculed a lot uh, because of what we call halo bias, the fact that it's a physician, they're gentlemen, they shouldn't have to wash their hands. That's what he had to deal with back in the day. In fact, he got so overwhelmed, he got psychiatrically affected. His colleagues were part of admitting to him to hospital. He was beaten there and he died.
Oh my gosh.
unfortunately, in
Wow.
the psychiatric hospital.
Oh my
So, but yet
gosh.
now we revere Dr. Semmelweis. So the idea was an invisible factor, germs that weren't understood back then, an invisible factor. What I'm saying, the analogy is now to extraneous cognitive load, to excessive cognitive load, that it matters and that uncontrolled stress matters, that it's affecting our brains. So how can we give more sense of control within the plan of the hospital? In other words, where's the wiggle room? Can we allow a little wiggle room with clinicians so that they have aligned autonomy?
Sure.
So it's aligned with the plan is of the hospital and leadership, but allowing some autonomy there. So it's aligned autonomy. And the other thing is that leadership is in a position where they can actually, they may not realize it because they haven't learned enough about human factors and cognitive load, but when they do, they can understand how important it is. They're in a position for resource allocation and workflows and so on, that we have great potential to do something about this. So I think the more education at leadership level, I think we'll make more progress. And they have, understand and have a lot of things to think about. And it's always the balance.
It is the
But
balance and the frustration, I can almost hear it is how much it might slow things down, in terms of implementing the new technology that has so much hope to even
right,
reduce that extraneous cognitive load. It almost feels like a couple of speed bumps that are keeping things from speeding along. And I think, I think of the expression invest now or pay later.
yeah,
Right? So it's better to gather all the data about the human side, so
right.
that it doesn't bite you later, right?
That's exactly
It
right.
doesn't catch you later and create more extraneous load and
Right.
not less later. And I often think about what you're saying also in terms of change management and transition planning. Just because you've introduced something doesn't mean that people have adapted it,
Right.
right?
Exactly.
Because they don't know how to. And they don't know how to integrate it with what they already have. So,
Exactly.
transition change management planning is a big piece, which, that could be another episode, but that's a very, very important part, of once you get the voice, whether it's a clinical review board or some or other feedback mechanism, now what? And the
Right.
consultants, of course, if it's a technology issue, should be part of that change management planning because that should
Exactly.
also be part of their expertise. So thank you so
Right.
much, Dr. Privitera,
Yeah.
Michael, for sharing your wisdom about cognitive factors and sociotechnology in not just clinician burnout. I mean, I know we've used
Yeah.
the healthcare industry as an example, but for people listening to this can apply to really any profession, this way of looking at things. So thank you so much for sharing this with us. And
Absolutely.
how might people contact you if they wanted to get more information or just learn more about you or connect in some way?
Okay. Well, I have a website put together with some of the literature that I've been involved in writing and trying to make it available so you can download it for free. My website is www.michaelrpriviteramd.com.
Okay.
And I'm in LinkedIn, and my email is michael_privitera at urmc.rochester.edu.
Thank you so much again. It's been such a delight, and I always learn so much from you.
Pleasure. Well, good to see you again, Sue.
Yeah. Thank you, everybody, for listening. This has been Tapping Wisdom.